Good morning, everyone. At the outset, a big thank you to Dr. Rajesh Fogla for including me in this wonderful course. So jumping right into it, I don't think any of us needs to discuss why we have DALK. Of course, by leaving behind the endothelium, we do have a much better opportunity of preventing rejections and other complications. So wherever there's an anterior pathology in the cornea, we prefer to have some form of an anterior lamellar keratoplasty, as you heard from the wonderful talks before. The indications for DALK, again, are varied, and we can decide what procedure works across the different conditions. The points to keep in mind, whether we're planning a manual DALK or a big bubble DALK, of course, is the underlying pathology which is there, the depth of scarring, which is very, very important, why that scarring is there, whether it's a post-hydrop scar or any other scar, and whether it's a central or a decentered scar, and of course, how the endothelium is. So there are various DALK techniques that we are aware of, and today I'll be discussing about my experience with the big bubble technique. So the great thing about many of our cornea surgeries is that we don't need too many very specialized instruments. There are a few instruments which can be got, and they really help for the surgery. So if you look at it from the steps of the surgery itself, the first thing we need, of course, are some form of trephines. So suction trephines are very useful. You get a very beautiful cut which is guided, and it is a guarded depth knife. You can also have handheld trephines, but in that case, then you need to combine it with a guarded depth knife, which you decide on. There are further anterior lamellar dissection. If you're planning to have it, the lamellar dissectors or the crescent blade. And of course, then for the bubble itself, you can either do it with a cannula or a gauge needle, 30 gauge needle. And very importantly, one instrument which I think is really helpful are blunt tip scissors. So the critical steps when we start the surgery, it's very important to mark. You can mark the center of the cornea, the center of the cone, and also measure what size you want to have your trephination. It is advisable, if you can see the Fleischer's ring, to try and include the Fleischer's ring because it's at the base of the cone. So then you are sure that you have included the entire cone, and the risk of you leaving behind part of a weak area is reduced. And of course, if you have a decentered trephination, then you can have problems ahead when you form the bubble also. So that's very important. The next thing which we come to are the partial thickness trephination. As I said, if you're using a suction trephine, then you have to measure pre-operatively and then use the trephination to mark. But what I do is use a handheld trephine followed by a guarded depth knife. Usually the keratoconus, no matter how thin it is in the center, the periphery will still be quite thick. So a 300 microns guarded knife is fairly deep enough. And it's important to go deep enough because that is a very, very important step to try and get the big bubble repeatedly, is that you have to go deep enough. And as in our learning phase, we tend to go superficial from the fear that we will perforate. The next thing is the anterior layer of dissection, which helps to debulk the cornea. This is not an absolutely essential step. Many surgeons would go ahead with the big bubble even without this, but it does help. If you debulk the cornea, then you have a much more predictable depth assessment when you're forming the big bubble. So you can go ahead and do this. Of course, if you have a very thin cornea in the center, that will again hamper your formation of the big bubble if you remove the entire layer, so you can leave it as a flap. So coming to a few videos about the big bubble itself, a few things that we need to keep in mind when we are injecting for the big bubble is the needle. So as again, initially we are very scared of perforating, so you tend to be very peripheral or you are very superficial. So you have to aim for, either the, maybe not exact center, but at least mid-periphery. Don't be too peripheral, and the direction is central or paracentral. And of course, we are scared that if you go too deep, we'll perforate. But if you're too superficial, you're going to get a lot of emphysema and will not get the bubble. We'll come to how we can predict that further. Next thing is, once you form the bubble, you have to release the bubble. Okay, and this is by what we call the brave slash. But before we reach the brave slash, and this will loop, so I just had a few points to show. Before we go to the brave slash, one thing is the paracentesis, because you want to make the eye a little soft. So you see the paracentesis is a very short incision. Following this, we put in air, which is the double bubble, which has been described even by Dr. Namrata and group, and then the brave slash. So before doing the brave slash, I put a blob of cohesive viscoelastic on the cornea. This has two advantages. One is it slows down the egress of air when we are releasing it from the bubble. And secondly, it's more visible that the air has escaped. The other thing which really helps us to assess whether the bubble has actually escaped is the air in the AC. So if you see that, now the air is in the periphery in the AC, and once you've released the bubble adequately, the air from the periphery in the AC moves to the center. If you don't put the air in the AC, what happens is sometimes if you have a little emphysema, it may look like some air escaped and you will mistakenly think that you have released the bubble. But actually the bubble is still there. So this really helps and has been very useful. The last thing about this step is that initially we used to make the brave slash very vertically, but now we've learned over years that it's okay to go in a little more horizontally. You can use the normal side port or paracentesis blade. So, go in a little more horizontally and move upwards. This way, the risk of you perforating the DM when you're making the brave slash is significantly reduced, and actually the air will not escape till you pull out your blade. It doesn't release as soon as you enter. The last thing is the posterior dissection of the stroma. So, of course, we do a quadrant incision and removal. Very importantly, here the blunt tip scissors are extremely useful. So, what you have to see is that after you've made the brave slash, your scissors should pass smoothly into the plane which is created between the posterior stroma and the DM or predesematic layer. If it is not going in smoothly, it means you're not in the right plane, and this can happen if your incision is too small or there's a lot of superficial stromal emphysema. You have to remove the ledge as much as possible, and here we try to keep the blades of the instrument as vertical as possible, because it's very important to have minimal ledging to ensure a good apposition of the graft-host junction. Remember that the perforation, even though initially we are more scared of perforation in the center, you can have a perforation even at the periphery because there will be a few additions of the posterior stroma to DM. So make sure you separate this well and then cut through. There are a few challenges, of course, but as long as we can keep a few things in mind, it's always a good easy enough. This is one sign which I have found to be quite useful. So if you notice the video on the right side, these very fine spoke-like structures are seen out of the emphysema, which will then, which will then predict the formation of the big bubble. And this would not happen in a normal emphysema. So if you normally our teaching is if you have a lot of emphysema, you must stop immediately, otherwise you're going to get a full emphysema all over the eye. The other thing is to understand the dynamics of the air. If it's trying to come backwards, better to stop, that you're not going to get the bubble. And of course, if it's tracking along the limbus, again, you're not going to get a bubble. So try to avoid keeping on injecting air in these steps. The last thing is that if you cannot find the bubble, as I said, it can be due to do two things. One is the incision is too small. In that case, you will have to find a way to increase the incision. Marking before you make your incision is very useful. It helps you to avoid losing that spot where you made the deroofing incision. So overall, obviously DALK is something that has been very useful. Big bubble DALK is a very useful technique. And if we keep in mind a few salient topics and points, it does give us repeatable results. And very rarely do we need to convert to a full thickness keratoplasty. Thank you very much.